Anyway, I'll be talking about toric IOL. I wish to thank AIOC and Posterior for giving this opportunity. So, as you all know, that today the target of hematropia is something that the patient desires, and all of us are looking at reaching this particular target. And toric intraocular lenses are something that is gaining in everybody's practice. So I'll run you through what the toric process is as regards clinicians, and then we'll talk a little bit on the design, the material, the optic haptic junction, etc. So what are the additional steps that one requires when to do when one is looking at implanting a toric intraocular lens? And these would be the pre-operative, intraoperative, or even looking at the post-operative. Now, there is a possibility of the potential sources of error which could get compounded. The first error is a proper biometry, and I'll be talking about the anterior and the posterior corneal astigmatism. Then you had to normally write it down. There's a transcription error, then planning error could be there. Then the marking, if you are doing the physical marking, there could be an error there. And then when a patient is lying down and when a patient is sitting up, there could be a torsional error. Then there is a surgically induced error as to how much you are feeding in for your surgeon or your different person surgery, capsular axis being imperfect and the lens getting decentered. And finally, the positioning, which is on the table, as also post-operatively, and how are you optimizing your outcomes for all these particular things. So when we are talking about the first part, that is the pre-operative examination, that is to measure the keratometry, which is very, very important, as also the biometry, which is very important. Now, one important thing that I'll wish to say is that the IOL power calculation should be done on an untouched cornea. If you are working on a cornea that has been invaded with, say, xylocaine, paracaine drops, or a tonometry has been done, or an A scan has been done, and you have touched, then the readings would not be good. The surface of the cornea needs to be optimized if we are looking at ocular surface disease, and then only we should look at doing the keratometry as to what is the correct thing. The next important thing that comes is a toric calculator, and this is important as to how accurately the data is being inputted. And the lens is normally recommended by the calculators, which each company has for their intraocular lenses, but you can also use a Barrett toric calculator if you want. Now, the third thing then comes is the marking. Majority of the ophthalmologists still do not have access to the markerless systems, whether it be the Callisto, whether it be the Varion, etc. So there is the dexterity that is required in doing a proper marking, and there are several techniques that needs to be looked at, and the person should be adept at doing a proper marking with the 0-180 degrees. Then comes the question of the intraoperative alignment and how are you going to place with the marked axis. So you can mark it on the table also, and the placement of the lens has to be there. And if there is a misalignment of the IOL, we'll be talking about it, that can cause a problem. And the final marking should be after the viscoelastic has been taken out and there is a nudge, maybe slightly clockwise, that is there for the final alignment. And then one day, 1 week, 2 months, or 1 month later, you have to do the post-op alignment check. There are several systems now. The femtolaser systems are getting you the marks, which can be seen later on. There is the steep axis alignment, which has come into the femtolaser systems, and the topography from, say, the Cassini will be passed on, and it will talk to the machine, and then you can have the alignment marks on the cornea, and you could align the toric marker, and then these marks can be seen later. There is also a smart thing of a round notch in the capsular axis, which will be remaining there, and you can look at that particular thing as regards the post-op measurements of the placement of the toric IOL. Now, I would say the IOL master, which is the 700, is among the best things, but if you don't have, you can do an immersion, A scan, and as I told you, a keratometry that is required. Autokeratometer and IOL master, autotopographer, all of them can be used, but the problem is, what are you wanting to measure? So it's the central ring, which at times is the best, which you want to take the central corneal keratometry, and this is better to measure the center of the cornea, and you can take it on 2-3 particular equipments. At times, a topographer, the axis difference is different from what a keratometer. A manual keratometer is really the best. An auto keratometer could give you, an IOL master could give you, and a topographer could give you different readings, and then you have to really decide which one to go in for. Now, when you are looking at the toric planning, there are three major issues. The first is what is called as the posterior corneal astigmatism, which I'll dwell in a little bit. Then the second is the surgically induced astigmatism of the surgeon, and third is what is known as a toricity ratio. Now, posterior corneal astigmatism, the first thing let us consider, a posterior cornea is steeper vertically, which translates to power horizontally. And that is at an average 0.5 diopters against the rule when the interior cornea has with the rule, and 0.3 diopters against the rule when the interior cornea has against the rule. That means that the posterior corneal astigmatism could be different or would be different from the interior corneal astigmatism, and it could be different as regards the difference between with the rule or against the rule that is there. Now, the anterior corneal astigmatism, there is a gradual shift with to the against from the to the against astigmatism, against the rule astigmatism from with the rule as a person ages, and this is about 3/8 of a diopter over a decade. However, the posterior corneal astigmatism remains unchanged, that is there. So posterior corneal astigmatism, there are several ways whenever you have a pentagram or a Galili, etc. And now they are trying to combine it with the OCT, but the simplest is to get the total keratometry reading on the IOL Master 700. That is something where you get, so you can see that if you are looking at this particular number, which is the TK, this is the anterior minus the posterior. You can also, on the Barrett's formula, have a proposed or a postulated TK, which can be done and which you should look for in cases of doing a toric intraocular lens. And the TK will be different from the astigmatism that is being measured in your particular case, which is there. So you can see here that if you look at the diopters here, 45.83, 46, and this is coming as 0.57. This is a combination of anterior and posterior. Now then let us go on to the toric calculator. So you can go on to their websites. Each company, as I told you, has separate toric calculators, and you have to feed in the entire range. And then you can rotate and you can say as to which is the lens, the axis, the power that you wish to do. Where is the, you can say calculation, this is the pre-op corneal astigmatism, this is the surgically induced astigmatism, this is the expected post-op corneal astigmatism basis where you're putting the incision, then IOL power cylinder and the residual astigmatism that you are getting. So you will get a printout of the power that needs to be implanted into the eye, and this is the product name and the power, etc. that you get, and you will order that particular lens which is there. And you have this summary as to where the lens has to be placed, where the incision has to be placed, and what is the steep axis. This is what you get in the cases. Now, one important thing for you is that 0, 180, sometimes people get confused. So this is the diagram which is 0, that is 0 and this, and 180 on this. So when you are sitting on the right eye, you have the temporal, this is temporal on this side, 0 on the left and 180 on the right. So this is how you have the 0 to 180 which is there. Now, the marking of the intraocular lens for on the cornea, in average, the IOL placement error is about 4.9 degrees, and it can go as high as 15 degrees. This is the average that you are getting because of the manual marking and the placement. So there is two steps. First is the pre-operative reference marking, and the second is the axis marking, which is the intraoperative step that you have. So the markings can be done using the bubble level, the gravity. It can be done with the slit lamp, blood vessel scanning. But if you are doing the IOL master with the Callisto, it will talk to each other, and the cyclotorsion, etc. can be there, and you don't really need to mark anything. These are various methodologies. Freehand marking, the patient has to sit straight on the slit lamp. This is the bubble marker that you have. This is the slit lamp marker that you have. So these are the ways that you want, and this needs to be very precise as regards the marking. Sometimes if you are marking, see, if you can see here, if this mark is here, that is fine. But if the hand goes down and the marking comes here, then it becomes a little problem, even though it is aligned 0-180, that is in this particular thing. These are sophisticated equipments, which is the aura, which very few of us has, because there is a click fee. So you go here, and once you are having the eye, after the cataract has been removed, and after the lens is placed, you can, the aura can tell you whether there is any rotation that is required or not, and you can get good outcomes with this particular thing. Now, once you have marked 0-180, in the intraoperative axis marker, you have to really tell where you have to put the lens, and that is what you mark on the table. The most important thing is that you need to dry up the cornea, and you need a pen which will not give you a very large mark. Now, the IOL needs to be therefore properly aligned to the axis mark, and there are 3 steps of intraoperative alignment: gross alignment, then you remove the viscoelastic with YA, and the final measurements that is there. This is just to show you a femto procedure that has been done. And you can see here, this is the incision. It is slightly different from the mark. And then you can see that this is the Callisto system, that after you have implanted the lens, you will actually need to see as to the alignment on the mark which is there. I'm just taking this forward. So this is the Callisto. This is the markerless system, the IOL 700 that is used. You put hydro. You don't want the chamber to become shallow, because there can be a tilt, and then you can mark the alignment that is there. Now, the post-operatively, the patient is showing you not a good 6/6 vision, and if on the autoref you are getting a plus and a minus, that means that there has been a rotation. So the best thing is to dilate the patients on the post-operative day, and to redial them if you feel that there is a difference. In a femto, if you have a mark here on the cornea, you can see whether this mark and this mark on the cornea is aligning or not. Otherwise, you will have to get the picture and see whether there has been a movement or not. Ideal is to do the realignment as early as possible. Now, let us see as to what the Invista toric platform offers us, which is one of the lenses that I have of choice, the IOL material, the haptic, and the optic design. Now, the hydrophobic acrylic material that is there gives you better bioadhesion between the IOL and the capsule, leading to minimal lens epithelial migration. The spring force of the haptics, which is there, is greater and does not degrade over the time, leading to good post-operative stability. And this is afforded the greater elasticity and the stiffer optic-haptic junction, and the optic-haptic is there. PCO is almost negligible in these particular cases. The lens glistening is not there. The Invista material is really great. It resists scratching also, and results in a stable IOL that remains largely unchanged by the intraocular lens. Now, the modified C loop has fenestrated haptics, which is again a good thing, which you don't see in single piece lenses, and it minimizes transmission of forces to the optic, and the optic maintains high quality, and there is more contact between haptics and the capsular bag. The step vaulted haptics are the other things which help reduce the PCO. So this is the hole that you see where there will be an attachment between the anterior and the posterior capsule. So it keeps it in place, as also this offset of the haptics to the, this is the offset that you have. So this pushes the lens down, and this, the sharp edge helps you keep the PCO. In a 2-year observational study of 106 eyes that have been reported, no patient underwent JAK capsulotomy, and the Invista toric is designed to resist growth of lens epithelial cells into the optic and limit PCO formation. So this is what I am saying. The other thing is the large contact area that you have, and these fenestrated holes, these are very, very important. And the interior offset of the haptic, as I told you, pushing the lens down, keeps the lens very, very stable, and exceptional rotational stability has been shown. So this is the precise rotation, which I'm saying is important. One day you can see, 1 week and 1 month it is there. A 10-degree off axis reduces the correction by 33%, 30% off axis, there will be no correction. And if you are 90% off axis, you will be causing harm to the patient, and you will be doubling the astigmatism of that particular patient. In US FDA trials, 92% of the eyes for Invista toric had less than or equal to 5 degrees of radiation at 4 to 6 months later. So Invista, to sum up, is a lens that is a lens of choice for me for the toric implantation. It is an abrasion-free optic, uniform power from center to edge. So even if there is some decentration, the problem is really not getting compounded in any way, and it gives you an increased depth of focus. You can see here zero abrasion lens, possibly at times better than a negative spherical abrasion correcting lens. So to sum up, toric IOLs are reliable tool to correct pre-existing astigmatism. They are better than corneal-based LRIs procedures. Cataract surgeons should adopt to toric IOLs in their practice to enhance patient outcomes. We are underdoing the number of torics that is required. We should look at the doing torics in anything, I would say, above 0.75 to 1 diopter, I would say. The only thing is that the company needs to possibly have a lower price for lower astigmatism that is there. Meticulous pre and intraoperative planning is required, and improved imaging modalities are the future. So thank you very much for your kind attention. Thank you.